Hi, this is Farm Fairy, and I just wanted to create a quick video on Borehaave Syndrome and chest pain. So I'll see how long this takes, and this is going to be my first video to post to my new YouTube account, and it's going to be awesome. All right, so I'm going to read to you the case, and then I'm going to go through my clinical thinking and how I came to this decision. So the case is of a 42-year-old man with a past medical history of alcohol misuse, found vomiting in the streets, brought to the ED by EMS, complaining of persistent chest pain associated with dysphagia. Pain occurs when he flexes his neck. He doesn't rate the pain. His blood pressure is 117/70. 101 is beats per minute, 18 rests per minute. O2 sat is 97% on room air. Physical exam, S1 and S2 is muffled by crunching sounds. The abdomen is soft, tender, mild epigastric tenderness. Bowel sounds are present. The electrocardiogram shows sinus tachycardia without ST wave abnormalities. Chest X-ray is lateral displacement of the left mediastinum, pleura, and what the question was, what is the most likely diagnosis? This question comes from pretest, and I went through the question. I'm not going to give you the answers, but what I came up with the answer was esophageal perforation and most likely Borehaave syndrome. So I'll talk about why I came up with that and a little bit of background on Borehaave syndrome and surgical treatment management. All right, so Borehaave syndrome was most likely a thoracic lesion. And I said thoracic lesion as opposed to a cervical lesion because even though the dysphagia tells me there's cervical involvement, you wouldn't have gotten you wouldn't have gotten what is called Hammond sign, which is when you take in a breath and you have ruptured your thoracic esophagus. It is most likely when you rupture the thoracic esophagus, you also are the 75% chance of rupturing the pleural, the parietal pleura, and so basically, you're most likely to get not only just a mediastinitis but also a pleuritis, and it's most likely going to be a right pleura, or like 80% of the time, and 20% of the time it's bilateral. And so this Hammond sign of the crunching with the heart sound is basically air comes in when you take an inspiration, it goes through the pleura, escapes through the lung, I guess, into the pleura, and then into the mediastinum, and then the mediastinum will then widen. So that's why I think this guy has that crunching sound. So the differential for this, so the differential, if you look at this case, really, I would say that the key finding here is the widened mediastinum, and so the differential for that is aortic dissection and Borehaave syndrome, ruptured esophagus. And actually, to say Borehaave syndrome really predicts that you're saying it's a spontaneous rupture and not an instrument rupture. So that's the difference between Borehaave syndrome and like esophageal ruptures. Most esophageal ruptures are actually iatrogenic due to instrumentation, and Borehaave syndrome or spontaneous rupture is actually not that common. So the management of a esophageal rupture would be immediately to put this person on NPO and antibiotics, and then you need to do some imaging. And current diagnosis says that you can do an esophagogram, which is basically serial X-ray images of the chest, and you do these serial X-ray images with a oral contrast that is water soluble, and so you don't want to precipitate a mediastinitis with a contrast that leaks out and is not water soluble and can't, survive the aqueous environment and causes reaction. And you can also do CT. CT will also tell you where this lesion is, and you want to know if it's thoracic or cervical. And and you never want to delay surgery. So it's really important that you ask the patient when did this start and do surgery within the next 24 hours, because after 24 hours of a ruptured esophagus, the tissue is not going to respond to surgical management. Basically, it's not viable to sew together. And the way you surgically manage a ruptured esophagus is it's kind of like Hartman's. It's almost exactly like it. So basically, you transect and you do a resection of the damaged esophagus. You create a distal stump close to the GE junction, and then you do a esophagectomy, esophagostomy, right? Ostomy is what esophagostomy, I presume, is how you pronounce it. And you divert the proximal esophagus through the neck and allowing the mediastinum to drain. And you want to get IVs, and basically the number one killer in a ruptured esophagus is infection. You'll see a mediastinitis as well as an empyema, which is very dangerous and is generally surgically managed. So in very rare cases of a small iatrogenic instrumentation esophageal rupture, you can just treat the patient with antibiotics, but it's a small rupture. And so the most likely infection that you're going to get from a ruptured esophagus is, according to Access Surgery, current diagnosis is staph and Pseudomonas. So whatever antibiotics that you're choosing, I would assume a tertiary cephalosporin will be fine. Okay, so I hope you guys enjoy this very short 6-minute video on Borehaave syndrome and one question out of pretest. And all right, bye.